Well, dear colleagues, I feel very honored and pleased to be invited for the second time to a global breast cancer conference in Korea. The first time was 5 years ago in Jeju Island, and I still have a lot of good memories about that meeting, for its scientific content, for the way, the really magnificent way it was organized, and for the many friends that I met for the first time. I was in contact before via email, and also many of those friends I stayed in contact after the meeting. I was therefore not hesitating even a single second when I got an invitation to be with you for the second time. GBCC is a large and important meeting about breast cancer. Within the field of breast cancer, we have a lot of aspects, going from screening over diagnosis, over treatment, and over afterlife after having had breast cancer, including, of course, also for those that we cannot yet cure, palliative care. All those fields have their developments, and it is difficult, even if you focus completely on breast cancer, to follow all the developments in all the fields. So my lecture will be Optimizing Radiation Therapy in Early Stage Breast Cancer. Radiation therapy, radiation oncology, is one of the important pillars of breast cancer care. And it's fully understandable that surgical oncologists, medical oncologists, and many more cannot follow all what has happened over the last years. And a lot is ongoing. Just like in the field of surgical oncology, where axillary management is changing dramatically, where also local treatments, mastectomy, tending more to breast-conserving therapy, oncoplastic techniques, etc. All this is happening, and we have to follow this because it has implications for radiation oncology. In the medical oncology field, new drugs, especially in the field of immuno-oncology, are being introduced. Well, in the field of radiation oncology, also a lot is happening. We are fine-tuning the indications for breast cancer patients, not anymore the one-size-fits-all. We are going more and more to tailor-made solutions. In this, we give less radiation therapy when possible, and we give a little bit more radiation therapy when required. So first of all, we have to recognize who can do it less and which patients require more. And when we speak about less radiation therapy, it's not only just black and white. There are a lot of shades of gray in between. Less radiation therapy is about which target volumes. We have the breast, we have the primary tumor bed, we have 5 levels in the axilla, and we have the internal mammary lymph nodes. Each of them can individually be determined as being a target volume or not for each individual patient. Subsequently, we have the size of those target volumes. For example, the breast, in low-risk breast cancer patients, we can go to partial breast irradiation. Then subsequently, we have the dose, because we don't need to give the same dose to all patients. Low-risk patients might do with less dose. High-risk patients might need to boost. And then, of course, which is another field of development, it's all about collaboration. And more treatments are being given in combination. There are some examples of combining radiation therapy with, for example, PARP inhibitors. There are other examples by combining it with chemotherapy like capecitabine. So in my lecture, Optimizing Radiation Therapy in Early Stage Breast Cancer, I will, for the entire breast cancer community, for sure not only for the radiation oncologist, give an overview of all what has happened over the last years and all what is currently being under investigation. Well, the future is the youth. So we need young people in the field of medicine in general, oncology in particular, radiation oncology even more in particular. But let's come back to breast cancer. Breast cancer is a disease which is hugely important for the society, not only because it impacts many women and some men, but it also has an impact on the society as a whole, because the woman and the men don't stand alone. They have their family, they have their caregivers, they have their working environment. Most people who have breast cancer will be cured. They will continue working and living in a society, sometimes with some limitations, but luckily enough for most of the patients, life will return to nearly normal. Of course, having had breast cancer changes a person. So breast cancer is important from a health perspective of view. It's also very important from a caregiving perspective of view. All our patients are individuals, and it is challenging to jointly with our patients go through the path of screening, diagnosis, treatment, and aftercare. And this can be done from a multitude of perspectives. You don't need to be a doctor to take care of breast cancer patients. Especially the specialized breast cancer nurses have a tremendously important role. In radiation oncology, the radiotherapy technologists have an important role of following the patients during the course of radiation therapy that they go through. The doctors, they have, of course, a central organizing role. They do most of the contact with the patients when it comes to explaining the diagnosis and the questions, giving answers to the questions of the patients and following them in the future up while giving them advices and having them in the best circumstances to proceed with life. Radiation oncology in particular is going through a huge evolution. Also in breast cancer, we see that the modern techniques, the modern approaches, the individualization of the care of the patients is coming through. We saw it before in, for example, head and neck cancer, but we see it now to the same level in breast cancer. And this is exciting. For the young doctors who are there to come, there is a lot to be done. You don't step into everything is finished and now you drive the car like it is. No, you step into a developing field, an exciting field where new things come in all the time, a field wherever continuously improvements are possible. When I see my career, which spans now over nearly 36 years in radiation oncology, always with an important component in breast cancer care. When I see at my field, it's tremendous how we evolved. It's similar to your first Commodore-like computer, going to the first PC, going to the first Mac, for example, and see what now you can do. Just on a small smartphone, we can do now more than my dad, who was a physicist, did on a mainframe computer in the 70s. And this is also in healthcare. We learned so much that in contrast to what we could do in the 80s, we now can do so much more for our patients. And what is particular in medicine, that it is about human beings. It's not just technology, it's just not just science. There is also the psychological component, the being together with the patient, the sharing with the patient. So then you come, of course, to why am I a radiation oncologist? And this is my message to the young doctors to choose for a profession like radiation oncology. You're together with your patients. You have an important task in guiding them, in being next to them, in having that human component. But it is also a pure scientific field, you have to learn, and you continue learning. And in radiation oncology in particular, there is also the technological component. Don't be afraid. We don't work with our computers. We supervise the medical physicist and the radiation technologist who are doing that work. We are responsible at the end. But our main profession, our main component contribution is being with the patients and supervising, taking care that they have the very best treatments. So join our field of radiation oncology, join the field of oncology. If you look into the ongoing research, to pick up a couple of real main features and keywords for the next years, in oncology in general, it is, and there are several words for it, individualization, personalization, all this where we're going to give the right diagnostic approach and therapeutic approach to the right patient. So balancing per patient what treatments she or he requires. This is what is ongoing in every aspect of medicine in general, not only oncology, not only radiation oncology. Another keyword is collaboration. Often combining less surgery with less radiation therapy is better than a lot of surgery without radiation therapy or a lot of radiation therapy without surgery. Combining is often, in most occasions, I would say, better. The same, of course, goes when we combine the local regional approaches, surgery, and radiation oncology with systemic therapies. We are more and more combining. And in this, we can decrease the individual intensivity of each component. So combination, collaboration is the second keyword. The third keyword, I would just say patient. We should not work around our patients. We have to work with our patients. The patients have to take care, to take part in the shared decision-making process, which goes on an individual level from diagnosis over all the treatments and the aftercare. But on a population level, it goes much further. It also includes options such as screening. So my third keyword is around the patient and sharing not only decisions, but also information. The fourth keyword is continuing research, continuing improvement. We get magnificent results now for most patients, not for all. So we have to look how to further improve it for those in which we don't have the optimal results now. And we have also to look to optimizing them for the big group of patients in which we have already good results, to decrease the intensity, to decrease the burden of treatment. And then I come to my fifth and last, and I would say it's hope. Hope for an even better understanding of the mechanisms of cancer and how we can maybe prevent women of getting breast cancer, or men, of course, but it's a lower percentage. So how can we prevent that somebody gets cancer? Now we know for lung cancer, don't smoke. For head and neck cancer, don't smoke, don't drink. For some cancers, it's HPV related. We can vaccinate, we can give advices. But we are learning now on the hallmarks of cancer, where it originates, in the genes, in the proteins. And in the future, we might learn from that how we can even prevent cancer at an earlier stage. And several mechanisms in immunotherapy But also in radiation oncology, there is a fantastic new development, which is flash radiation therapy, in which we maintain the same tumor effect, but we have much less complications. So that's why hope in the better understanding of the cancer, so that we can further develop and fine-tune our prevention, our treatments, and hope in better treatments for those who we need to treat. So that are my 5 main keywords: personalization, individualization, the patient, shared decision-making, collaboration, combination, continuing research, and hope, because we are learning so much that it will even get better and better. Yes, as a final word, I cross my fingers it will be an in-person meeting. After 2 years of pandemiseria, which is a combination of pandemia and misery, after 2 years of pandemisery, we need to meet. We need to discuss in person. All those virtual tools are very valuable. They can add on and they can replace in case of urgency. We started in August with the first bigger meeting worldwide, which was Estro in Madrid. It was so good. While there was a lot of hesitation initially, afterwards everybody said, "Oh my goodness, I'm so happy I came." This was the best experience in more than a year after having had no in-person meetings. So my message is very clear to those who are seeing this short interview: be there in person. Only if you really cannot go, okay, participate to the hybrid virtual component. But I will be there in person, unless I have to swim. That's too far. But I hope there will be planes so that I can travel from Belgium, Europe to Korea. Be there, and I'm very much looking forward to seeing you there.